policy measures as well as behavior change interventions for reducing salt intake, and we are starting it at a very opportune time. And I'm sure this e-dialogue with impactful discussions related to global best practices as well as the needs, and also having youth ambassador, which is very, very important because after all, the behavior change should be starting from within, and youth ambassadors are leading this cause. So I welcome all the esteemed speakers, panelists of this e-dialogue, as well as all the attendees. And I believe that this is going to be a very fruitful discussion, resulting in important outputs as earlier. Thank you. Over to you, Dr. Subbar.
Thank you very much, ma'am, for those opening remarks. And as you rightly said, as Indians, for some reason, we eat more salt. Some of the studies even put it at 11 to 13 grams per individual per capita per day. That's too high and way higher than or more than double than what dietary guidelines for Indians 2024 of ICMR and recommend it. The capping of the salt is recommended to be around 5 grams per day, but that's too high. And often we tend to blame this on highly processed food and prepackaged food alone. But as you rightly said, there are also our culinary practices which are very much important to be noted. Now it's my pleasure to welcome Dr. Imran Syed Farooq to give his opening remarks. But before that, I would want my team to introduce him, to give a brief profile.
We are honored to welcome Dr. Imran Syed Farooq, Executive Director, RTSL India, a seasoned public health leader with over 20 years of experience in stakeholder engagement, public-private partnerships, and sustainable health systems. For the past 8 years, he has successfully led multidisciplinary teams across Southeast Asia. Since 2020, Dr. Imran has served as Chief of Party for USAID tuberculosis private sector project in Indonesia, spearheading national efforts in health financing, capacity building, and private sector engagement in alignment with national health priorities. We look forward to his presentation on overview of LFOF New Life Initiative. Thank you, sir.
Dr. Imran, it's a pleasure to have you. Please, can you give your remarks?
Thank you. Thanks, Dr. Subbarao, and thanks for that introduction. So good afternoon, everyone. It is a pleasure to join you today at this important e-dialogue organized by ICMR and IN, and to speak briefly about the Let's Fix Our Food New Life initiative, a collaborative platform focused on improving nutrition literacy and reshaping food environments in India. I would like to begin by expressing my sincere appreciation to Dr. Bharti Kulkarni, Director of ICMR and IN, for her leadership and vision in championing India's food and nutrition agenda. I would also like to thank Dr. Subbarao and the niche division team at NIN for their pivotal role in organizing this timely e-dialogue and for their continued efforts in driving this important work forward. It is truly an honor to collaborate with such committed partners. India today stands at a critical crossroads, as Dr. Subbarao as well as Dr. Bharti Kulkarni said, that we are witnessing rising levels of obesity, diabetes, and hypertension, not only among adults, but increasingly among adolescents. A key contributor is the growing consumption of high-fat, sugar, and salt foods. Poor diets are now one of the leading drivers of non-communicable diseases, particularly the cardiovascular disease. LFOF, Let's Fix Our Food, initiative emerged in response to this growing challenge. At its core is a shared vision to reshape food environments so that healthier choices become easier, accessible, and aspirational, especially for the young people. Phase 1, led with great foresight by ICMR and IN, established a solid foundation. With the support of all the consortium partners, the initiative produced impactful policy briefs, convened national dialogues, and engaged high-level stakeholders on issues such as front-of-pack labeling, HFSS food taxation, marketing restrictions, and nutrition literacy among adolescents. Importantly, it created a space for young voices, like we have Ms. Jia today with us, to be heard and taken seriously. Building on that momentum, we are now entering phase 2. LFOF New Life, as both Dr. Bharti and Dr. Subbarao said, that this is nutrition literacy and improvement of food environments. So with renewed energy and sharper focus under NIN's continued leadership and in collaboration with GHAI, UNICEF, and with other members of the consortium, this phase seeks to accelerate evidence-based policy action and embed nutrition literacy interventions into the mainstream platforms. There are 4 core pillars for this phase of intervention. The first one is research and capacity building through e-dialogues like today's, publications and development of validated adolescent nutrition literacy scale. Second one is broader coalition engagement, like with ministries like Ministry of Health and Family Welfare, Ministry of Education, and premier institutes like FSSAI and NITI Aayog. The third one being bringing a strategic focus on salt reduction, healthier fats, and skill-based nutrition education for adolescents. And finally, the fourth pillar is knowledge translation. So bringing global insights into action tailored to India's unique food systems and cultural context. Importantly, the initiative continues to serve as a unified platform for multi-stakeholder public health action, bringing together policymakers, researchers, educators, youth and civil society to collectively move the needle on food policy. I'm especially pleased that today's session coincides with the World Salt Awareness Week, providing the perfect platform to spotlight salt reduction as a cornerstone of public health strategy. As endorsed by WHO, reducing salt intake is among the most cost-effective interventions to lower hypertension, stroke, and cardiovascular disease. It directly supports the Government of India's target to reduce population-level salt intake by 30%. It is also heartening to see how young people are stepping forward as change agents, learners, and leaders to build healthier food environments in their schools and communities. Their role in this moment is central, not secondary. To close, I want to reiterate LFOF New Life is not a standalone project. It is a shared mission. And we are proud as Resolve to Save Lives to walk this journey with ICMR and IN and all our committed consortium partners. As we scale, let us amplify what works, build momentum where it matters, and stay grounded in the voices and needs of our communities. Together, we can fix our food and build a healthier, more equitable future for every Indian. Thank you.
Thanks a lot for those very encouraging and very straightforward message. And one key message that I take back from your talk is that we all know, but we do very little about it, that salt reduction is the most cost-effective and easily doable measure to combat the growing menace of hypertension and other non-communicable diseases. Thank you very much. Now I think is the time for 3 presentations. As I said, these 3 span over the global best practices and then regional and then the country level initiatives. So to start with this 3 talks, I request my colleague Archana to introduce our first speaker.
We are honored to introduce Dr. Kathy True, Program Lead of the Nutrition Implementation Research at the George Institute for Global Health and Director of the WHO Collaborating Center on Salt Reduction. She also serves as a Senior Lecturer at the University of New South Wales. With a background in public health nutrition, Dr. True's research focuses on implementing and scaling up evidence-based nutrition strategies to prevent non-communicable diseases. She is recognized expert in sodium reduction and leads a global initiative to switch the world's salt supply to potassium-enriched salt. She has helped translate global evidence into local actions across 10 countries by designing, implementing, evaluating sodium reduction interventions tailored to local context. Dr. Kathy True, the floor is yours. Thank you.
Hi there. Thank you very much for the introduction. Can you see my screen okay? Great. Okay, so it's a real pleasure to be invited to the talk today, and I'd just like to start by thanking ICMR and IN, Resolve to Save Lives, for the opportunity to present to you today. As mentioned, my talk is around reducing salt intake and why it matters. So firstly, let's start with a bit of background. Both globally and in India, non-communicable diseases account for more than half of all deaths now. And that's primarily deaths from cardiovascular diseases such as heart disease and strokes. And in India, 1 in 4 deaths are due to cardiovascular diseases. And so it's no surprise that the leading risk factor for deaths in India is high blood pressure, which has already been mentioned. And this is also the case around the world. So it's no different in India. And as you can see here, high blood pressure causes more deaths than air pollution, high plasma glucose, which is a risk factor for diabetes, as well as smoking. And so that's really why we really need to tackle high blood pressure. And so what are the causes of high blood pressure? Well, there's quite a few risk factors, but the main one, the one that contributes to high blood pressure the most would be high salt intake, as well as increasingly we're understanding low potassium intakes. But today I'll focus on high salt intake. So high salt intake or high sodium intake causes high blood pressure because it causes a retention of water, and then that retention causes a higher blood volume, which then causes sort of pressure on your arteries, increasing your risk of having a heart attack and stroke, as well as kidney disease and early deaths. And so that's why excess sodium from too much salt is a huge problem. And we know from well-researched studies conducted over several decades that there's a direct linear relationship between sodium or salt and blood pressure, as you can see here in the diagram. So the greater the reduction in salt intake, the greater the reduction in blood pressure. And so that's really important to remember. And the physiology behind sodium and blood pressure, it's really rooted in our prehistoric diet. You know, we have to remember for most of human evolution over millions of years, humans consumed actually very little sodium and much higher potassium, as you can see in the graph. In our hunter-gatherer ancestors, they typically consumed fruits, plants, some meats, and they all contain little bits of natural sodium. And so that's why our bodies have evolved to be quite efficient in retaining sodium levels for survival. And actually, the addition of salt for preservation or flavor actually occurred only 5,000 years ago. And that's when it was first introduced, but only mass production of salt happened a few hundred years ago. So our bodies haven't evolved to be taking in so much sodium. And as I mentioned, you know, in the past, we consumed a lot of potassium through the plants and fruits, and nowadays we're not consuming as much potassium. And interestingly, studies in Yanomamo Indians who are living a fairly primitive life in the Amazon, they consume almost no salt or sodium, and they actually don't have high blood pressure nor adverse health consequences of consuming low sodium levels. And nowadays, in our modern diet, most populations worldwide consume excess sodium. As you can see on the graph, the bottom black dot represents the global average, which is double the recommended intakes. The estimated levels for South Asia were around 9 grams of salt per day, both of which are almost double the recommended levels at 5 grams of salt per day, as shown in the light blue line. In India, estimates of salt intake, they do vary a little bit, but we can be sure that it's around double the recommended levels. There are some studies showing about 8 grams of salt intake a day, up to a systematic review that showed an average of around 11 grams of sodium, 11 grams of salt a day. And this varies because of different measurements, but also different places that they might measure salt intake. But as I mentioned, determining the exact level isn't important. We know that, like most countries around the world, India is having too much sodium, almost double the recommended levels. And so since the population in India as well as worldwide consumes too much sodium, which causes high blood pressure and cardiovascular disease, we really need to lower it. And reducing sodium intake on a population level is actually really important, because what it does is it shifts the whole population's blood pressure downwards, regardless of those that have really high levels of blood pressure or sort of moderate levels of blood pressure. It just shifts the whole population's blood pressure down. And even by shifting it just by a little bit, say, for example, 2 millimeters of mercury, that would lower stroke deaths by 10% and lower heart disease deaths by 7%. And so small reductions in sodium intake as well as blood pressure on a population level have a huge benefit. And another reason for why reducing salt intake is so important is because treating high blood pressure is just not enough. As you may already know, 1 in 3 adults in India have high blood pressure or hypertension. And actually half of them don't know that they have high blood pressure. So they're not actually treating it or doing anything about it. And only 1 in 10 people with high blood pressure have it effectively controlled, whether it's through medicines or other ways, to normal levels, but only 1 in 10. And the other thing to remember is people that have blood pressure that over 115 millimeters of mercury actually have an increased risk of cardiovascular disease. However, they're not receiving any treatment at all. And so that's why reducing population salt intake will benefit everyone in the population, not just those people with diagnosed high blood pressure. And so in our modelling study that we did last year, we put all this information together and showed that by lowering salt intake in India by 5%, could prevent 1.7 million cardiovascular events, 700,000 cases of chronic kidney disease, and 300,000 deaths over 10 years. And this can be achieved by reducing sodium levels in packaged foods. Whilst we recognise that in India, most of the sodium comes from salt that's added at the table or during cooking, there's still about 20 to 30% that comes from processed packaged foods. And that's increasing as people in India are consuming more and more processed and packaged foods. So we've taken that all into account in our study and demonstrated that by limiting the sodium content in processed and packaged foods, we can reduce population salt intake in India and substantially reduce cardiovascular and chronic kidney disease deaths. This intervention would also be cost saving. It would save the government money by implementing this sort of intervention. So I wanted to finish by concluding on why reducing salt intake matters. As I mentioned, high blood pressure is the leading risk factor for deaths in India as well as globally. Most populations in India and globally eat too much salt, and lowering salt levels on a population level would lower blood pressure on a population level, thereby substantially reducing cardiovascular events and deaths every single year. So I'll finish there. Thank you again for the opportunity to share why I think reducing salt intake matters, and I'm happy to take questions later. Thank you.
Thank you. Thank you very much for that very important presentation, which set context for today's e-dialogue. While we have some questions to ask you, but we request you to just stay back for the other presenters to finish so that we can take all questions together. For all the participants and the attendees, you can post your questions in the Q&A box or in the chat box, or you can raise your hand and then we will take your question. The questions for the 3 presentations will be taken at a time, and 1 round of Q&A will be after the panel discussion. So stay tuned, and then we'll have our next speaker. Dr. Angela, thank you very much for joining from WHO CRO. But before you start your presentation, I'll request my colleague Sanjana to introduce you.
Thank you.
I would like to introduce our next speaker for the day, Padmini Angela De Silva, Regional Advisor, Nutrition Health for Development, Department of Health, Population and Non-Communicable Disease at the World Health Organization Southeast Asia Regional Office. With over 25 years of experience as a medical doctor and public health nutrition specialist, Dr. De Silva provides technical guidance and advocacy on nutrition, physical activity, and related health issues across 11 countries in the WHO Southeast Asia region. Her work focuses on key areas such as infant and young child feeding, micronutrient deficiency, obesity prevention, and creating healthier food environments through regulatory action and policy support. We look forward to gaining from her deep expertise in advancing regional health and nutritional initiatives. Thank you, ma'am.
Thank you very much. And I'll be sharing my slides now. Please let me know whether you can see it.
Yes, you can put it in slideshow mode.
Yes. So thank you very much, firstly, for inviting me to join this very interesting series of discussions. And I'll be focusing on evidence-based salt reduction interventions and what works. So in the next 10 minutes, I'll try and share some global best practices and some from the region. Just excuse me in that I put a little extra detail in my slides in case anybody wants extra information, but I'll be just speaking briefly for the next 10 minutes. So reducing sodium intake is a key component of preventing unhealthy diets and hypertension, as Kathy mentioned before. And WHO has done cost-effective analysis for some of the policies, and it is very clear that policies such as reformulation, front-of-pack labeling, food procurement and service policies, behavior change communication and mass media campaigns, and food marketing restrictions are very cost-effective for lower and middle-income countries. Other recommendations of WHO include those subsidies for healthy diets, menu labeling, limiting portion and package size, and nutrition education and counseling. So what I would like to also emphasize at this point is salt reduction should be within the entire context of improving diets and overall context of healthier diet. And one point that we forget to generally mention when we talk about hypertension and sodium is the importance of increasing potassium intake through fruits and vegetables, because there's plenty of evidence to show that increased potassium intake for adults and children does result in reduced blood pressure. Overall, dietary guidance, the global strategy on diet, physical activity and health, optimizing infant and young child feeding, and also implementing some of the actions in the comprehensive implementation plan on maternal, infant and young child nutrition are very, very important. So basically, sodium reduction should be across the life cycle. Now, I'll share some of the experiences. One of the original experiences came from UK, where there was voluntary reformulation targets set in 2006. So the target setting included a development of maximum and average or sales-weighted voluntary targets for key contributors to salt intake. Basically, the targets were comprehensive across a large group, food groups that were the key main contributors to salt. And the aim was to gradually, stepwise reduce sodium across all packaged processed foods with added salt. In addition, there were also complementary measures on the out-of-home or what we call ready-to-serve foods, where restaurants and shops were encouraged to reduce salt, ensure availability of low-salt options. In addition, food labeling, UK has a traffic light labeling system, and awareness campaigns to support implementation and maintenance of targets was carried out. And UK is a very good example where there's plenty of the robust evidence show the impact of salt reduction. So if we consider the packaged foods themselves, salt content in many foods reduced by 20 to 50% across the timeline. And what is more important is that there was assessment of salt intake, blood pressure, and CVD mortality in England from 2003 to 2011. And it showed that the salt intake reduced from about 9.8 grams a day to 8 grams a day by 2011. At the same time, there was a significant reduction in blood pressure and deaths per 100,000 per year, which could be attributed to reduced sodium intake. In UK, most of the reduction in hypertension and sodium intake was largely driven by reformulation. And what actually worked? So there was very strong political leadership at that time that supported this whole initiative. There was a good establishment of a good private-public partnership with industry, where there was a good understanding of the need to reduce salt. Setting targets across a comprehensive set of food categories was important, as well as strong monitoring and evidence of impact. As we saw, there was very good, robust evidence of impact. There was a lot of media coverage and public awareness, and though the targets were voluntary, they were sort of quasi-mandatory in that there's a lot of pressure on industry where the government praised those who actually reduced the sodium levels in their products and named and shamed publicly those who did not. So in this instance, voluntary actions on reformulation worked. Then we come to another country, Chile. In 2016, to promote healthier food environments, they brought in 3 actions, and these are regulatory actions. One was the food labeling and advertising law. There was restrictions to decrease exposure to unhealthy food marketing in children, and unhealthy foods and beverages could not be promoted or sold or distributed free in school environments. And after 4 years, there was evidence to show that the proportion of foods that were high in sodium reduced for most savory food groups. There were changes and these changes increased as the regulation limits were tightened. In this case, what worked were the mandatory regulations, evidence that there were no financial impact on industry by reducing sodium, and also stakeholder lobbying and robust monitoring. And this graph, what it shows is the relative difference between nutrients and calories purchased during Chile's labeling regulation time period versus a hypothetical expected trends of purchase if there were no policies. So if there were no policies and there were no warning labels, you could see that there were much more purchases of sodium, high sugar products. Whereas in reality, because of the warning labels, because of all these regulations, there was less purchase of these products. Then another example from closer to home comes from South Korea. Again, they had a voluntary salt reduction program with the behavior change campaign, availability of low sodium foods, and voluntary reformulation and sharing of low sodium recipes. With the South Korea program, population salt intake fell by 23.7% in 2014, that is over 4 years, accompanied by reductions in average population blood pressure and prevalence of diagnosed hypertension. Here, what worked was a multi-component strategy where food industry opposition was countered with a lot of dialogue, education events for industry, providing R&D support for industry to develop low sodium products, like, for example, low sodium kimchi. Momentum was driven by consumer and parent associations. And also there was supportive economic analysis that demonstrated the benefits for reduction in terms of healthcare costs. Singapore, in the last couple of years, has implemented a national strategy to reduce salt intake by 15% by 2026, which is about 1/4 teaspoon per person per day. And the focus is to reduce sodium consumption to reduce hypertension. So Singapore took a different approach It's a four component approach with industry incentives, which give grants to industry to reduce salt, sauce, and seasoning, reduce sodium in these products, and also to promote adoption of these low sodium products by the food and beverage industry. They also brought in policy changes in food procurement by the government, where there's a policy on whole of government healthier catering policy, where the government will only contract those F&B industries who provide low sodium products for all their government functions and so on. So this is a very powerful change agent in reducing sodium intake. There's also a consumer education campaign of less salt, more taste, as well as a sodium reduction pledge by food industry that commits to reduce sodium in products and replace with lower sodium options. This also, the sodium reduction pledge is voluntary, and the assessments will happen in the next couple of years, and we will see the impact of it. Philippines has brought about a food procurement strategy, particularly just one city in municipal government in Philippines, where they establish nutrition standards for all foods and food suppliers. And here, the patients in hospitals, shelter home residents receive healthy meals, which are also low in sodium. And many employees are trained on procurement and food provision. And the assessments haven't been done yet, but what has worked so far is the fact that there is a dedicated multi-sectoral platform, involvement of communities, organized civil society organizations, and a lot of opportunities to help small businesses to provide local support for these businesses to improve their meals and reduce the sodium levels. Finally, I thought I will also share one of the recent advances in India, reducing salt in social safety net programs. So the ICDS Poshan Abhiyan program has nutrition norms in place, such as, there has to be a meat or a fish or a vegetable, but there were no standards for macro and micronutrients. And there's evidence of high sugar, salt in the take-home rations and the hot cooked meals, which was when compared with the latest dietary guidelines for Indians. And therefore, the MOWCD issued a directive on the sodium and salt content in these take-home rations and hot cooked meals, and also a directive on sugar. So no refined sugars, jaggery in minimal quantities, avoid or minimize use of salt, and high-fat sugar foods to be avoided under the social network, safety net programs. And this was promoted by NIN as well as WHO. There's no implementation plan as far as I know, and no, I beg your pardon, there's no monitoring plan as yet, but I'm sure we will see changes as we go along. In the interest of time, I will not go into details of some of the work being done in other countries, but Indonesia, Thailand, Nepal, and Sri Lanka in this region have ongoing work. For example, the front of pack traffic light labels of Sri Lanka, the food reformulation efforts going on in Indonesia, Bangladesh, and Thailand, behavior change communication across all countries, cafeteria policies, and public food procurements. So finally, what are the effective strategies and what can we learn from these examples? So evidence is very important. Evidence of high sodium intake, the impact of lowering salt, its impact on health and economies is important. Sharing good practices from successful countries and what has worked is very important. Political leadership is vital. Clear context-specific policies, because what works for Chile may not work for India, but you can get some ideas on what can be implemented and some activities can be identified which would support it. I also particularly want to mention that when we talk about reducing sodium, we also need to always ensure salt iodization, which is one of the key public health measures that need to be kept in mind. And that is why I put it in red, because we tend to forget about talking about salt iodization when we talk about salt reduction. Both are compatible, but we have to keep this in mind in our policies and plans. Multiple policy actions for food environment. One action is not enough. Just FOPL or food reformulation is inadequate. Multiple policies need to be implemented by countries. Strong advocacy is important. Community awareness and demand along with a supportive environment. So BCC is important, but you have to have a supportive environment to support the changes. And along with reducing salt, the message on increasing potassium through fruit and vegetable intake has to be popularized. Private sector has to be engaged for reformulation, and robust monitoring and evaluation is vital. So I will stop there and happy to answer any questions as we go along. Thank you.
Thank you. Thank you for that very, very good roundup of what's happening globally and what's happening in the region. Thank you very much, Dr. Padmini, for that very good roundup. And then we'll have certainly several questions coming your way. I think we request you to please stay back with us. While I'm very happy to inform you that Dr. Swasti Charan, who's the DDG in the Ministry of Health and Family Welfare. And I know sir, and I've been interacting with him. His commitment towards NCDs and his zeal in the work is extraordinary. We're very happy to have him. In the first phase of LFOF, he promised to be there at the release of the policy briefs, but because of his personal travel, he couldn't make it. We're very happy that you're here now, sir. And we would want to hear from you what the government initiatives are. But before that, I want my colleagues to introduce you to our attendees today.
It's our honor to introduce Dr. L. Swasti Charan, sir, Deputy Director General, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. In his pivotal role, he oversees a wide array of national health programs. Sir holds an MD in Community Health Administration from Delhi University and the Masters of Public Health from the Massey University in New Zealand. He has further specialized through fellowships and trainings, including a WHO fellowship from Liverpool University and leadership programs at Johns Hopkins and Emory University, USA. With his extensive experience, Sir is committed to integrating health programs for more effective implementation, translating scientific evidence into policy, and fostering innovation in healthcare delivery. With such an inspirational background and wealth of experience, Sir, we are honored to have you with us today, and we look forward to your insights and reflections on salt reduction. Thank you.
Thank you very much for inviting me for this very important workshop. As the DDG looking after national program for the NCDs, I'm very, very interested in today's program, because as I try to look after the 1.4 billion population of this country, I find that many of us are suffering from already the NCDs. Many of them are heading towards it. Many of them have not initiated any of the risk factors. But what is common for all of us is the salt. Salt somehow is being introduced very early in life, and that also without being monitored in the way we should all be doing it. So because of this, because of these fact, the health impact on salt, because of the excess dietary sodium, the blood pressure invariably is raised in many of us and is the leading modifiable risk factor for cardiovascular diseases. One of my colleagues who is working in nutrition, one day told me that, Dr. Swasti, if we discover salt, the salt that we use today, a little later in the civilization, it would be classified as a poison. And so that was a very great statement that he made. And now as I look after the NCDs, I can understand what it means. India's salt consumption, we have already heard the previous speaker stating that 8 to 11 grams of salt per day on an average is consumed, and this is roughly twice the WHO's recommended maximum 5 grams per day. So this comes from many ways in the table salt, the cooking salt, and also hidden in certain kinds of foods, which is very, very prominent in this part of the world. And we all know that we have also adopted a goal of 30% reduction, relative reduction in the population sodium intake by 2025, and we are already in 2025. So when we are struggling with this, even though we have got global practices across the world, for the time being, when I look forward in the kind of work we do, the NP-NCD program is trying to, put 75 million people on standard treatment guidelines for diabetes and hypertension by 2025. We have done a lot on this. We have put them on treatment. We know by far we have crossed 75 million in this country, and we still have some more months to go. But while we are happy that we have achieved this, what makes me worry is we have closed the tape little bit. We have closed the tape, trying to prevent the cardiovascular diseases and other cardiac events like the myocardial infarctions or stroke or any other related diseases due to hypertension. The tape is just partially closed. So what we need to do to completely close the tape as far as cardiovascular diseases and other after effects of hypertension is we should have certain policy recommendations. So one of them could be mandatory limits and levels, adopting clear self-reduction regulations and association organizations like the FSI has got a very big role to play. The second would be food reformation targets. We set and enforce gradually lower maximum salt levels in packaged foods. And we also heard the previous speaker speaking about iodine, and my colleagues who are working in National Iodine Deficiency Disorder Control Program comes and tells me that, because of the awareness you have created for hypertension, people are consuming lesser salt and thereby consuming lesser iodine. So should we increase the concentration of iodine in the soil? I said, no, I don't think that's the right time for us now, because some people are aware, some people do consume less salt, but the majority of people continues to consume more salt than required. So if you increase the concentration of iodine in the soil way beyond what we have now, it could have adverse effects which is not desirable. So that aspect is one we need to focus on. The procurement policies. I also appreciate the speaker who had rightly said that charity should begin at home. So the midday meals, the ICDS and the hospital meals that we serve in the country, in all the health facilities, there should be a model healthier diet and protect this vulnerable group of population which are already suffering from some disease. And then once we do that, they can carry back the messages home and then implement at home. Public education is another, starting from school. So many of our children nowadays are aware of many of the environment laws, what is banned, what is good, what is not good, even to the extent of tobacco products, etc. But as far as I know, for salt, I don't find many of our school children coming back and telling the parents that we need to do this. We continue to enjoy some of the indigenous products in form of pickles and snacks, etc. One of my colleagues who is a clinician, he told me a joke saying that he advised the person to avoid salt because he was having hypertension, and then he comes back the other day and the next day and tells me that after 1 week he tells him that I have avoided completely the salt. Then the doctor, he asked him, how do you manage this? I said, no, I don't consume any more salt. I consume the pickles and that's enough for me. So in a way, we are not able to communicate properly. We are not able to convince them properly. So we need to close this loop together. As a public health fellow, I always believe in prevention, health promotion, starting from health promotion and primary and secondary prevention, and also closing the loop. Like if someone is suffering from a disease which has an origin in tobacco, which has an origin in excessive salt consumption, they should come back and tell the population that because of this I suffered. I don't want you to do that. So the healthcare workers should also routinely counsel patients on salt reduction, avoid training in and also encourage training in medical curricula, and we should not take salt for granted. So that's what I wish to convey in today's workshop, and it's a very important workshop. And I wish after the workshop that the organizers would, provide us a report so that we can look into it and try to see what we can do from the national program for NCDs in the Ministry of Health. With this, I thank you once again for inviting me.
Thank you, sir. And the very purpose of having an insight from your side was also to have an exchange of some information from here to the policy and then how it can impact, and no better person than you with your commitment to take it forward. So thank you very much for being here. I request all the three panelists to be around. There are a few questions in the chat box. I'll just ask those questions, and then I also have one or two questions before we go in for the panel discussion. The first question is about from Dr. Aisha, our colleague. She asks, how effective is low sodium and high potassium salt in controlling hypertension? Should this be promoted? Who would take this? Dr. Kede, you would take this?
Sure, happy to take this question.
Yeah, please.
Thank you. It's a good one. So WHO have recently recommended for those that use regular salt to replace it with lower sodium, high potassium, or potassium-enriched salt substitutes. It's, as some of you know, it tastes and looks like regular salt, so that's one of the huge benefits. Another huge benefit is it not only reduces sodium, but it increases potassium intake. And most populations worldwide, including India, don't eat enough potassium, as the main sources of potassium are fruits and vegetables. So it has that dual benefit on lowering blood pressure and thereby cardiovascular diseases and early deaths. There's very clear evidence from large-scale trials around the world that show that switching to potassium-enriched salt substitutes will lower strokes by about 14%, cardiovascular events by 13%, and premature mortality by 12%. So huge benefits there. And the other thing to mention is that they are a little bit more expensive than regular salt, but as there's an increase in demand and hopefully supply, that will drive prices of potassium-enriched salts down.
Okay. And a question to Dr. Swasti Sharan. The question is about you mentioned something about iodine concentration. One of the participants has not gotten idea of what you said, but if I rightly understand, that's about if one reduces salt, what about the iodine in the salt, the iodized salt that we consume? Sir, I request you to take it up.
Yeah, thank you, Dr. Subara. I was giving an anecdote. One of my colleague who I also happen to look after the National Iodine Deficiency Disorder Control Program in the country as the DDG. So one of the proponents for salt iodization, he comes and tells me that, sir, you look after the National Program for NCDs, and you have done so much for hypertension control that people are aware that salt consumption is harmful for the hypertension. So they have started reducing the salt consumption. So because of that, several studies have shown that the iodine consumption, which will come from the salt, has reduced drastically in some sections of the population. So I am worried that, as you control hypertension, we would start having population who would be having iodine deficiency. That was his theory. Then I told him that, then he was giving me a solution, telling me that, if that salt consumption reduces, should we consider increasing the concentration, per gram of salt, how much iodine it is already there. So should we increase this? And I said, I don't think we have got enough evidence at the scale of the population that we recommend, putting more iodine per gram of the salt that is being consumed. So that was a thought which was shared with me, and I still do not have the answer yet. And I would look forward to more evidences before taking any action in that direction.
Yes. Sir, I would like to also ask you about the 30% salt reduction goal. Are we working anywhere in terms of getting the industry to reformulate their products? I think as you rightly said, we should work along with FSSAI, and happy to say that LFOF has FSSAI as one of the consortium partners, we will certainly take it forward. And some of our scientists from NIN are part of FSSA's panels, and then we're sure we take it forward. But are there any concerted efforts in the lines of what our Honorable Prime Minister said about reduction of fat or oils, cooking oils in our daily diets? Is there any such advocacy or promotion to engage with the industry to give perks for reduction of salt?
Very frankly, not from the NP-NCD program. But what I must tell you is that we have a mechanism which is known as the National Multi-Sectoral Action Plan. So we have got around 38 line ministries. Out of them, 15 of them are key, very important line ministries. So we do take up in that forum that why we need to work as a whole of government approach or a whole of society approach. But per se, for achieving the targets, Ministry of Health under the program, we haven't done anything directly. Probably, as you said, we need to engage more with FSSAI, which seems to be, the custodian of that particular target. But we would be happy to, join hands with them in terms of health promotion, in terms of increasing awareness through the network of national program for NCDs that we have in this country.
Thank you, sir. Dr. Angela, there is a question for you, which, of course, this is a question that everybody asks. The dietary guidelines for Indians clarifies it amply, though, but there are questions about pink salt, black salt, Himalayan salt, whatnot, all different kinds of salts. Are they a great replacement for the real salt reduction? That's one question. And also, of course, one of the participants says that sodium sources are many others, including some of the additives and preservatives in the bakery products and things like that. So that anyways is understood, but salt commonly is something that we can easily try and avoid or can regulate more easily. So that's one. And then there are several questions that are coming in, but you may please take this question about different kinds of salt. And then we will move to the panel discussion and come back to question and answers a little later. Yes, please.
Thank you. Thank you, Dr. Subbarao. So to be honest, there's no difference between whether you eat pink Himalayan salt, black salt, or the usual sea salt that we have. All have almost similar amounts of sodium, maybe minute differences which do not really matter. The problem with all these artisanal salts is not really the sodium, but the fact that they're not iodized. And as people tend to eat these and they're not iodized, you may end up seeing some iodine deficiency. But these are very niche products and they're expensive and they're not, commonly consumed by the general population. So yeah, that's the main answer to the question. And what was the other one you wanted to, somebody asked about, what was the other question?
And that's about what you answered in the chat box about sodium coming from other sources as well. And also the iodine titration that you talked about, and that's answered in the chat box.
Fine, thank you.
Thank you very much for taking these questions. And if time permits, I request the panelists to please stay back for another round of questions towards the end after the panel discussion. Now we move to the next and important step of getting views of multiple stakeholders in the panel discussion. To introduce our panel, I request my colleagues Archana and Sanjana to please take it forward to introduce all the panelists at one go, and then I'll have a few questions, one round of questions for them, and then we can quickly go in for question and answer session with the participants. Yes, please.
Now I welcome our first panelist for the day, Dr. Rupa Shivashankar, a senior scientist at Indian Council of Medical Research, where she leads implementation research on non-communicable diseases. Dr. Rupa holds an MD in Community Medicine from All Indian Institute of Medical Sciences, New Delhi, and an MSc in Epidemiology from the London School of Hygiene and Tropical Medicine. A physician scientist with 2 decades of experience in non-communicable disease research, program implementation, and policy advocacy. Dr. Rupa specializes in the prevention and control of cardiovascular diseases and diabetes. Ma'am has authored around 80 peer-reviewed publications and played key roles at organizations such as Resolve to Save Lives and Public Health Foundation of India. We look forward to her insights on advancing public health strategies to combat non-communicable diseases. And I also delighted to welcome our second panelist for the day, Professor Chef Atul A. Gokhale, Director of Symbiosis School of Culinary Arts and Nutritional Sciences at Symbiosis International University, Pune. With over 35 years of experience in culinary education and the hospitality industry, both in India and abroad, he is distinguished educator, chef, and an academic leader. An alumnus of IHM Bhubaneswar and former chef with Indian Tourism Development Corporation, Professor Gokhale specializes in Indian and Italian cuisine. He has contributed significantly to culinary education policy and curriculum development, and is currently pursuing doctoral research on a maturity model for culinary education in India. He serves on several national and international advisory boards and is known for his work in food history, Vedic cuisine, and recipe development. We look forward to his valuable insights into culinary innovation and education. Thank you, sir.
You're on mute, Dr. Subbarao.
Archana, would you also introduce the other two panelists for us? Am I audible?
Yeah, you're audible.
Yes.
We are excited to welcome Ms. Jiaz Chaudhary, a bright and enthusiastic grade 12 student from Evergreen Public School, New Delhi. With a passion for learning and a curious, open mindset, Jia is committed to exploring new ideas and embracing challenges. She is eager to grow, share, and engage with her vibrant community. As an inspiring example of youthful determination and enthusiasm, we welcome Ms. Jia Chaudhary. And next, we are honored to introduce Punita Singh, an experienced educator with over 20 years of teaching biology. She holds an MSc in zoology from Rani Durgavati Vishwavidyalaya, Jabalpur. Punita ma'am is known for nurturing scientific curiosity and fostering critical thinking beyond textbooks in her students. A strong advocate of experiential learning, she has led students tours to NASA in the USA and exchange program in Singapore. Ma'am's dedication to hands-on learning continues to inspire students to explore and engage with science in innovative ways. We welcome all the panelists to today's session. Thank you.
Thank you very much. And we're very happy to have multi-stakeholder panelists. We were also trying to get somebody from FSSAI. Unfortunately, we couldn't get them as the scientific committee meeting is day after tomorrow. So they're all engaged. But nevertheless, as I said, some of our NIN scientists are part of FSSAI panels, and then we will take forward these messages. So we want to have different perspectives. We have a researcher and a research administrator, a culinary arts specialist, a student, and a teacher. That I'm sure gives us a good, thorough, all-round understanding of what we want to do and what we have to. My first question is to Dr. Rupa Shivshankar. I just want to know if there are any current research priorities in the medical arena, medical field, especially from ICMR, on salt reduction per se. Yeah, I know NCDs is one of the focus areas for research and high health priority research area, but are there anything on salt reduction per se? If so, what are they?
Thank you, Dr. Subbarao, for inviting me to be part of this panel. And it's a pleasure to meet previous colleagues, friends, and new people on this meeting today. And thank you, Dr. Bharti. I believe is she still there? I'm not sure. Hi, and Dr. Angela, I hope you remember me. And I would like looking forward to meet you, Dr. Syed, in the near future. Okay, and thank you for the question. We had heard very excellent talk just in the previous hours. I think they mentioned in thoroughly with what has been done, what has been accomplished in the research, in what evidences we have got for salt and its effect on health and potential reduction strategies, both globally and in the region and in India's some part. So coming back to the priorities, what needs to be done in India, so we do have some sense of the sodium consumption in the country, which is the salt consumption, which is kept around 10 to 11 grams, varies from 7 to 11, depending on which survey we look at. But there are pockets in the country which do consume very high salt, about 20-25 grams a day as well. I don't think now estimating actual salt intake is a bigger priority, the description, but I would say current priorities would be to number one, to understand the sources of sodium, which we have at certain level, which is the added salt. However, given that India is a very diverse country, our culinary foods changes from region to region, it's very important to understand what food contributes maximum to the salt in various different regions. That's one priority. Second priority, and this I recently learned, and I would like to learn more. Maybe I have to read a little more, and maybe Kathy or Padmini, if they have a more insight into it, could be able to help us, is the relationship between the substance use and salt intake. This came up when I was in east part of India in Bhubaneswar, and the people talking about how the tobacco and other substance consumption reduces your sensitivity to the salt, and people tend to consume more salt, which becomes a double whammy. There is a risk due to tobacco, and tobacco making you to increase your salt intake. So, which I hadn't realized, at least I hadn't come across so far. I really thought in very interesting area of work, and how do we work on both of this two risk factors together. I think more or less that's where the understanding part of it. But finally, I want to say the major focus of sodium reduction should be on implementation research. Dr. Angela talked about various different strategies used by different countries. And India is all of those countries in different regions. The strategies used in UK might work in some of the metropolitan cities of India, or we have Vietnam in other eastern part of India, and there are tribal communities and there are rural communities which require very different strategies. We will need to experiment and see what messaging, what strategies, and what policies will work for different part of the country. And that's the major thrust now should be to conduct implementation research on how to reduce salt in the diet. I'll stop there and I'll get back if there are more questions, Dr. Subbarao.
Thank you for that. And then I was also meaning to ask you about, because you've also worked on a few behavioral interventions and also low sodium salt interventions in your previous avatar. Are there any, low sodium substitute or so, other, is it the sole strategy, or what is are there any studies that have demonstrated behavior change interventions? If so, what they are, which have been successful in reduction of salt?
Thank you. So the low sodium salt is definitely one of the very important strategy, and Dr. Kathy gave a very good information on that. However, that's definitely not the only strategy. And again, I want to emphasize on this aspect, specifically in certain pockets of this country. I met with a team of researchers who wanted to use low sodium salt as an intervention to a tribal community where their actual salt consumption is around 20 to 25 grams, as they said. And I wasn't sure that is a strategy for that community. We have never tested low sodium salt as a strategy when the consumption of salt is that high level. So so low sodium salt will only work. There has to be a reduction in salt intake per se, then replace that with a lower sodium salt. I think that is very important to take in thing. So just stepping back, what are the three ways, I was thinking through it, what are the three ways you can reduce the dietary salt? Either not add salt, reduce your salt content in your food, or reduce the salt containing food, that is high salt food, or replace the sodium part with another part, which is potassium, typically with the low sodium salt. Now, what has worked, I don't have to repeat what Dr. Padmini has explained. The various strategies have worked, whether it is front of package labeling, replacement, or the manufacturing, reducing the salt, which worked very well in UK, and the strategies that worked in South Korea. Unfortunately, Dr. Subbarao, we haven't been able to demonstrate behavioral change, reducing actual salt reduction in India. There was one study that was conducted by the George group in Telangana. But while there was a reduction, there was an improvement in knowledge and attitude and practice, but there was no demonstrated reduction in salt intake. And however, there is a very good study which they had piloted where they showed low sodium salt substitute had shown a reduction in blood pressure and also in reduction in salt intake. Again, this was in Telangana. And one study that has worked well, but that is very specific population in Assam, is in tea garden population, where they worked on reducing salt in the tea. But that is a very specific group of population. But what about the mainstream population? We still need to generate evidences in terms of doing a good strategies and doing a good implementation research.
Thank you. Thank you for that. And then my next question goes to Chef Atul. Thank you, sir, for but since you're also a food history enthusiast, I would want to know from you, were the Indian diets historically high in salt, or was it something that we picked up along the way? And are there any tips that you usually give in your practice to your students to reduce salt, especially when making Indian foods, because you specialize in Indian foods and Italian foods?
True. Thank you so much, Dr. Subbarao. And I really want to thank ICMR, NIN, and Dr. Bharti Kulkarni over here for giving me this opportunity to be amongst the peers, amongst the people who have been experts in the nutrition, and especially when we talk about the topic of salt. Although very ignored topic, especially from the point of view of the people who implement cooking. And I would say the people generally at the chef's level, at home levels, the housewives, or at the commercial level, at any different food outlets, awareness that the salt reduction has to be done is zero. I mean, let me be very honest about it. And the message which we talk about over here as implementers, as policy advocates and policy implementers, the people who are actually cooking are not aware of how much and what to use and why it should not be used and what harms are there. So an important part, I would say, first I'll go into the tip question. The second question I'll go first, because that's something which is very important. The cooking methods by itself, which are used by the chefs, the cooks, the homemakers, the bakers, and all the people are not aware of how exactly the salt is causing hypertension directly and how it is related. It is generally taken that salt add kiya, so it will become tastier. With the spices and all. So training of cooks, training of people on the ground level, I feel through FSSAI or through bodies like NIN and ICMR and other organizations is very, very pertinent. And that is something which we do at our college level. And I just generally say to the students and to all the people over here is stop adding salts to chapati, puri, or atta or rice preparations that you make. We generally have this habit of beginning the kneading of our doughs by adding a salt just to get the extra taste. Then instead of having a salt which could be increasing, that we find it little lesser salt, add some tangy items, tangy food items to the food item like lemon juice or any other imli or any other tangy products which can be added to it. Instead of adding salt, a tangy fruit could increase the taste and acceptability of salt level in the food. And importantly, don't sprinkle any amount of salt on the table on any of the foods, including salads, dressings, or anything which is there. So something which we can do is take away the salt and pepper shakers from the restaurants, from any other places where addition of that, or even chaat masalas and the food items which generally people use in different types of toppings can be done in. Why I'm saying this at this point is traditionally we have never ever been having a salt issue in our foods, because the salts which were used were all the traditional 5 types of salts. It could be senda namak, it could be the vida namak, kala namak, or any other salts which were combination of these. And one important tip which probably I can share over here is do the variation of the salt usage into your day-to-day food items. Rather than having one particular table salt being used, you can have different variety of salts for different food items that can be done. Another thing which probably I have learned over the way of teaching students is, instead of using RO water for cooking, try to use the tap water. Probably that gives you the required amount of natural salt coming from water. I may be wrong at this time, but then I think the RO water, which takes away all the natural elements, natural minerals and contents, probably should be, maybe we can use that kind of in water as well. And finally, I would say that traditionally we have always been high on eating potassium-rich foods, not sodium-rich foods. Dr. Subbarao.
Thank you very much. I was just making note of a few things, but you missed on my first question also, Dr. Atul, about traditionally, were we consuming more salt?
No, we were not. In fact, we were consuming very less salt, or the salts which were, if you see, I mean, as Dr. Kathy in her slides mentioned, that the salt consumption artificial started 5,000 years ago. Traditionally, before that, any of our traditional food books, and if you see, salt was hardly mentioned into the cooking item. It naturally came in from different food items, even like milk. A reduction of milks and a natural salt found in the milk was considered as the taste substitute or a taste enhancer within the food items.
Okay, thank you very much. That's very important. Now I'll go to Ms. Punita Singh. Thank you very much for joining us and being patient. The salt intakes are already high among school children. Around schools, you see a lot of salty foods being sold. And within the canteens, usually sometimes, are there any guidelines in place for schools? Because you've been in schools and school management for a long time. I know FSSAI has been holding on to the ban on sale of HFSS foods around 50 meters around the schools because of a proper definition of HFSS. But nevertheless, are there any policies that some of the schools like yours or others that you know implement? You please unmute yourself.
Yeah. So good evening to one and all present here. Yes, we do realize that, and we do understand children today, especially young children, school children, have developed a taste for high salty snacks, food, etc. We do understand, and it is the need of the hour that and it's very nice that we are, talking about this at a platform like this wide platform. And, in schools, if we see from the tiffin boxes, which are packed with chips and packaged food, it's full of it now. Their salt intake is so high that they're not even realizing what they are putting in their mouths. So what is the school, as you said, guidelines of the schools, etc. So different schools, I'm sure, have different guidelines, because yes, there is that 50-meter radius. We cannot sell high fatty food, high salt and processed this thing. But is everyone following it? That is the concern. So if I talk about my school, yes, we do a bit from the school management, the teachers. We have school canteens. I'm sure most of the schools do have school canteens. They either supply lunch to the children or snacks to the children. So these canteens, what are the major point that we need to target? So we as teachers, we have teams of teachers which have duties where we see what is being made, sugars are they putting, the processed sugars, the oils, etc. Because, am I audible?
There's some disturbance in your audio, but still you can go on. I mean, it's breaking a bit. Yeah.
Okay. So how much processed sugars, how much oil are they putting? That all we need to see, and we have a systematic, let's say, communication with these vendors and the canteen chefs, because they are accountable. We have to hold accountable. They have to be accountable for what they are feeding the young children. Sir, am I audible to you?
Yes, you are.
Okay. So that is there. So we do have random checks in the canteen. As
That's
teachers,
nice.
we go and eat in the canteen and see what is being served over there. But all said and done, we all know that vendors will want to sell their food. And as Sir said, Atul Sir said, a dash of chaat masala and extra black salt and namak will always make the pani puris and the pav bhajis in the canteen much tastier. They want to sell the food. So this is where education comes into play. We need to educate the young minds when they're very young. We need to teach them what are they putting in their mouth, what are the advantages, disadvantages, what is this high salt, that common salt that they call it, what is it going to do to the heart, to the kidneys, to their blood pressures. So teach them young, teach them to be aware of what, and we have in our schools SUPW classes, we have home science classes, we have these biology classes, of course, where we teach them to break down the food and how it is absorbed in the body in a very practical manner. And then once the children are aware of this, they even convey it to their parents.
That's nice.
They convey it to their parents.
We actually found a similar thing in one of our food labeling studies, wherein we taught children to use the food labels, and then they went and conveyed it to their siblings and then parents. It's a good one. And I also want to ask you, were there any instances that you personally faced when your school or somebody wanted to reduce salt in a particular dish, and then parents came back saying that you're not making it healthy, try and make it healthy? How did you overcome such a situation, if at all?
In fact, no. We've had these taste sessions in the school. We have these counters put up, especially on PTMs and all, where we train our children to, as teachers, we help the children. But in fact, it's been the opposite. We've reduced the sugars, we've reduced the salt, we've reduced the oils, and we've made the parents also taste it. And they've been in fact very happy about this change. And so after that, there's been an open communication with the parents, where we've been sending them WhatsApp parent groups that all the schools have these days. So our school, we keep sending them recipes for low salt food intake, how they can send this in their tiffin boxes. So these are few measures that the school is taking.
Yeah, checking the lunch boxes is one good measure, though, but it also sometimes is a bit sensitive issue. But nevertheless, thank you very much for those inputs. Now, I am looking forward to interact with our youth ambassador, Jia, who's been waiting patiently for a long time. Jia, thank you so much. I hope your summer vacation has started, but still, it's a good time for you to recharge yourself, to inspire more and more people to get into nutrition advocacy. Jia, how often do you see the chips, snacks, salty foods being sold around your schools? And do you, as a youth ambassador, check the food labels?
Am I audible now?
Yes, you are.
Yeah, thank you for your question. I'm truly delighted to be here today on behalf of the Public Health Foundation of India. As a youth ambassador under the Let's Fix Our Food LFOF initiative. Before I begin, I would like to express my gratitude to ICMR NIN for this opportunity to be a part of such an important conversation and being given a platform where young voices are not just heard, but valued. Coming to your question, to be honest, like any other of my peers, have been easily influenced into eating these salty snacks and enjoying a packet of instant noodles every now and then. I would often reach for them during school breaks or late night study sessions. Uh, at the time, I thought I was simply choosing what was quick and comforting for me. A big reason why so many adolescents fall into this pattern is the way these foods are marketed. Flashy ads, attractive packaging, and the constant promotions, especially when they are endorsed by our favorite celebrities and influencers, make it so easy to get attracted to these food items. They make these snacks seem fun, cool, and even rewarding. It's no surprise that many of us don't think twice before picking them up, like me. And of course, there's the convenience factor, the easy availability, as we have discussed. So the easy availability of these items and the fact they are low cost, tasty, and literally within arm's reach, making it even more tempting for us to grab them without even considering their long term impact on us. This is why I appreciate these initiatives like Let's Fix Our Food LFOF. That has helped me understand the actual effects of HFSS foods, high in fat, salt, and sugar foods. It isn't about weight gain, but also about energy, mood, and focus, and how these foods are shaping our health habits at a very young age. So now I've been consciously trying to reduce my intake of processed snacks, limiting them to once or twice a week. I'm exploring healthier alternatives like homemade options, fruits I follow, although the roasted snacks that satisfy my cravings without even harming my health. Uh,
Good.
being being an LFOF youth ambassador has helped me see how critical these choices are, not just for today, but for our future. And after hearing so many conversations which the panelists and the guests shared, I felt so bad of choosing salty food earlier.
No,
Yeah.
no, you should tell us now how you're going to take forward and build more ambassadors like you who will talk about healthy eating and reduction of HFSS, especially salt.
Yeah, I'm looking forward. I truly believe that change begins with us, with open and honest conversations. One of the first things to do is to raise awareness in school, maybe by exploring interactive assemblies and fun activities like quizzes and games focused on these low salt consumption and its hidden presence in everyday snacks and its effect on the body of younger individuals. Being a school cabinet member gives me a platform to lead these initiatives like Low Salt Week, where students try out the tasty and the healthier alternatives to these high salt snacks. These activities don't just inform, they involve adolescents, giving them a voice. And that's what makes this impactful. But awareness doesn't stop at school. We have social media. Everyone is on social media. It's a very powerful tool in today's day and age, and can be utilized very creatively through reels and stories and posts that share the bite-sized facts, the relatable memes, the quick tips on making low-salt choices. The message can reach to a greater audience. Peer influence is very powerful, as I mentioned before. And when messages come from someone of your own age, they're more likely to resonate. Beyond individual efforts, there's a need to build something lasting, like a student-led nutrition club we can have, where we could also discuss food choices. Like I'm here on the behalf of my school fraternity, cooking ideas, and as mentioned, a label reading, all in a space that's open and non-judgmental. These conversations can spark a real shift in how we see the food we eat. As adolescents, we have the energy, creativity to accomplish anything and to lead grassroots changes. From
Yes.
starting school kitchen gardens to organizing healthy recipe contests or workshops, we can on decoding food labels. Our efforts can influence behaviors at a broader level.
Thank you.
If given the chance, we would also like to work with health communities and school authorities so that we can monitor canteen offerings as mentioned for the HFSS food on the campus. Yeah. In the end,
Thank
peer
you.
education, creative outreach, and a sense of ownership are the tools we need. Thank you.
Fantastic. Thank you very much. That's like a true ambassador. I hope you build the club that you're talking about in your school, and then
Yeah, we
so that
have
you'll have,
this
yeah.
club already.
Oh,
We just need
fantastic.
some changes and modifications and learnings.
Thank you. And then build more youth leaders like you in your school. Thank you very much for those interventions. We've had a beautiful session. And then there are a few questions on the chat box. While Dr. Rupa and Dr. Padmini have been continuously answering questions in the chat box, I thank them very much for their patience and then the responses that they've given. Nevertheless, there is one question that remains unanswered. Somebody asked, Subra is asking why Andhra Pradesh has a little higher intake of salt. Is there any specific reason? Can anyone take it? Dr. Rupa, you can take this question.
I'm not sure
Yeah.
whether it is only Andhra Pradesh which has got very high intake of salt. There
Yeah.
are quite a few. Just taking a step back, the people who consume higher calories tend to have higher salt intake.
Correct. Correct.
That
Yes.
is related to your calorie intake.
Yes.
So rural communities tend to have higher salt intake compared to urban area for the sheer because they consume more calories. That's one reason. And the communities which consume higher salt food like chutneys and pickles and papads and those kind, they tend to have high salt intake. And there are tribal communities, could be part again in Andhra Pradesh, whether it is Odisha or Chhattisgarh and those people, lot of them just consume salt and rice, and that is the main part of their meal. Okay, that contains very high levels of salt because that's all you're eating. So tend to have very high salt consumption, which goes up to 20-22
Yeah,
grams
even
as
dried
well.
fish, fish, salted dry fish. Yes.
Yes.
Pickles,
Yeah.
papads, all they
Yeah.
contribute also.
Yeah.
Yes.
And when you add a lot of chilies, you tend to add more salt to get
Yeah.
more
Exactly.
taste
Yes.
out of
And
it. So
one of the reasons that I was trying to say is generally Telangana and Andhra have a lot of spicy food.
spicy
Perhaps
food,
that's the
yeah,
reason why they
spicy,
add more
oily,
salt.
which
Andhra and
increases the salt.
Telangana people love hot rice with ghee
Right.
and pickle. Their
Yeah.
pickle is the staple thing that they mix with their rice and eat. It's
Yes. There is one question that if Dr. Kathy is still online, I would want her to take this question. Aside from restricting added salt in cooking and refraining from processed food consumption, are there any formulations or foods that can slow down sodium absorption, analogous to how glycemic index foods help moderate glucose absorption? Are there any specific foods that will reduce? So for those who don't want to reduce salt but want to reduce salt absorption, the question is, yeah, can you take this, please?
Sure, thanks. That's a really interesting question. Look, the main mineral that interacts with sodium is actually potassium, and that's something that we've spoken about a lot. And so what potassium does is it has pretty much an opposite effect to sodium. So in some populations, we've seen that you can have high sodium, but if you also have high potassium, that counters some of the effect of sodium, the effect that sodium has on blood pressure. So, if you're consuming more fruits and vegetables, they're often high in potassium, and so they counter the effect of sodium causing high blood pressure. It doesn't affect absorption in that physiological mechanism, but it does have a physiological interaction. So I'll sort of describe it like that. Yeah, thanks.
Thank you. Thank you for taking that question. And how to read food labels to check salt? I'll take this question. This is, the FSSA has recently made it mandatory to declare sodium content in the food. Ideally, the sodium should be 1 mg per kilocalorie, not more than that. It should be much less than that. So sodium, you can just check the sodium, how much it is there in each of the foods that you're taking. Also, you can take as per the the serve size. So if it's given for 100 grams, you can calculate it back per serve size based on the sodium content that is declared on the label. Now it is mandatory in Indian context also. You can check that. And then, yeah, are there any more questions that we did not take? And thank you for patiently taking many questions here. Youth ambassador is very impressive. We have to have more and more youth ambassadors is a comment that somebody posted in this. Love your energy and enthusiasm, Jia. All praise for you. Thank you very much. And yeah, we've had a lovely session. There are a lot more questions in my mind to ask, but I think we have very limited time. It's my 5 key takeaways that I have from this e-dialogue that will go into probably an action mode from here. One is that, we've seen very clearly that reformulation of foods, encouraging industry to reformulate foods seems to have really helped in some of the countries. Yes, that can start in our country as well now, but most of the countries which have initiated these, we are told, have requested the industry to do it on a voluntary basis. Thoda Kam initiative, Aaj Se Thoda Kam initiative of FSSAI attempted to do it, but in trans fats, the promises of the industries to keep them low have really helped, and then a stronger policy also has helped. I think similar initiative in Indian scenario should be tried out, but as I said, the processed food intake is still a bit low when compared to what we cook at home. But nevertheless, if we, as Katie already said, if we reduce salt from the processed and prepackaged foods, we are reducing as much as 30 to 35%. That's a good start. So reformulation, encouraging reformulation, I think now it's time for LFOF initiative to work with FSSAI to come up with some initiatives to encourage industry to reduce salt by reformulating their foods. And second, an unequivocal vote is about continuous public awareness and education by all. But my take on this would be that we should all disseminate the same message, whichever quarters we are talking about salt reduction on a public level. So I think it's a uniform messaging about low sodium salt or reducing salt itself, and also consuming more of potassium rich foods, especially while we encourage reduction of salt content, we should also encourage consumption of fruit and vegetables a lot more, which will also enhance our diet diversity and also reduce the impact of salt. So those are the three. And then the fourth one is the importance of closing the BCC loop that Dr. Swasti was talking about. The behavior change communication has been a very scattered effort, but it has to have more, stronger evidence-based behavior change communication initiatives are required in Indian context. And for that, the fifth and the most important measure that Rupa was talking about was that we need to invest in implementation research, wherein we show and demonstrate the usefulness of policies or behavior change measures. As Ms. Punita Singh said about the policies that are required at school level, do they, when implemented, do they really result in reduction of salt consumption or not, is one thing that we can look at. And also perhaps a study, some studies that can look at salt consumption per se, reducing salt consumption, salt intake at the table level and at the culinary level. And the second one is about checking if that compares very well with the low sodium salt intake, and vis-a-vis the third one, reducing salt plus increasing potassium rich foods consumption. Can we have interventions at an implementation level on groups to check how these three measures together and independently help reduce salt? So these, according to me, are the 5 key takeaways. And of course, I'll not undermine the importance of teaching the culinary arts students and the people who prepare food, because convenience foods and us consuming food outside or away from home is now increasing. So we are relying more and more on the foods that we are being served outside. So the culinary arts education should integrate some element of nutrition into it. And then, yes, Professor Atul, we will work towards it as we've been planning for a long time. We welcome Culinary Arts Association, if there is any, to be part of the Let's Fix Our Food initiative, and then we can take these things forward. So these are my 5 key takeaway messages from this e-dialogue. And then we'll have a series of more e-dialogues coming in, some on fat, some on sugar, some on nutrition literacy in future, because this will form the basis for our policy advocacy and policy briefs in future. Thank you all for being patient. Thank you for joining us and across the time zones. And thank you very much for being here with us. And I thank the audience for being very patient for a 2-hour-long webinar, which demands a lot of attention, and the span of attention these days has gone really low with a lot of gadgets that we have around. Thank you very much for being part of this. Thanks, everyone. And then before I wrap up, I have a duty to thank RTSL for supporting this initiative, the Resolve to Save Lives. And I would profusely thank Dr. Imran, Dr. Manika, Mr. Vivek, and Dr. Sanjay Pandey for their constant support. And many, many thanks to our DG ICMR for encouraging LFOF initiative. And then we are in the second leg of it, and then we are sure going to come up with more and more impactful advocacy. And my thanks to Dr. Bharti Kulkarni, our director, always encouraging, always supportive. Thank you very much, ma'am, for your presence and then for your support for this very important initiative, and then for your initial opening remarks and for declaring this second series inaugurated. And also, I'll thank all my panelists, Dr. Kathy, Dr. Angela, and also Dr. Swasti Charan. Dr. Swasti Charan has left because of his other commitments, and my panelists, Dr. Rupa, Dr. Atul, and of course Jia and Punita ji. Thank you very much for being here. And last but not the least, my colleagues Archana and Sanjana, and of course others, Ishani and Paramita and Rishikesh Panda, who have been helping us, and all the team at NIN, ICMR, and PHFI, UNICEF, and all other consortium partners of LFOF. Thank you. We will inform you. Please join us in the subsequent webinars, which are going to be on very important topics like this. And then we'll keep you posted. Please follow our NIN social media pages for more and more updates. Thank you all. Thank you very much. We'll make the recording available with the consent of all the presenters. On YouTube, this is already there, but this also, the recording will be made available if it is consented. We'll write an email later for taking your written consent. Thank you very much.
Thank you. Thank you very much.
Thank you. Thank you so much, Dr. Subbarao. Thank you.
Thank you.